So the topic is on IV versus PO antibiotics, challenging the deeply entrenched dogma of IV superiority. So this is a very popular and relevant topic, so I'm glad you guys are able to join us. So in terms of disclosures, I've only received honoraria from academic organizations for giving talks at CME events. I don't take money from drug companies. The objectives of the talk is I'm going to aggressively debunk the myth that IV is better than PO. I will show you which types of infections can safely and effectively be treated with oral therapy, review the pros and cons of IV and oral administration, and then finally, I will propose a set of simple criteria that you can use to guide you on when to use oral antimicrobials. So if you haven't seen the Therapeutics Letter 155, I encourage you to do so. My presentation will reflect a lot of the content from this letter. So I'll start off with a case here. This is a 53-year-old man with native aortic valve infective endocarditis caused by Enterococcus faecalis, complicated by septic emboli to the kidneys and spleen. The blood cultures have cleared on IV antibiotic. There is no immediate plan for surgery, and he's ready for discharge. So you're consulted to finalize his treatment plan. What do you recommend? Finish 6 weeks of IV antibiotics, do 2 weeks of IV antibiotics, then switch to PO. Only switch to PO if the patient requests it, or only switch to PO if IV administration is not feasible. So feel free to lock in your answer. So I'll stop the poll now. So the vast majority of you picked answer B, which is actually the most evidence-based answer, but does that actually happen in real life? I would say no. So this is what happened to the patient. He finished 13 days of IV ampicillin and ceftriaxone, which is pretty standard therapy. Then he was switched over to amoxicillin plus linezolid. Linezolid was switched to moxifloxacin after he developed some cytopenias. And so in the largest RCT of endocarditis called the POET trial, where they compared partial oral to IV therapy, dual oral therapy was used for every patient to ensure that at least one drug maintained adequate drug levels to kill the bacteria. So future studies might inform us if using 2 drugs is really necessary. This patient had finished his 6-week course of treatment. He subsequently had his valve replaced several weeks later. A culture from the explanted valve was negative, and he had a successful outcome. So I'm going to start by debunking some myths. So this is myth number 1. So many of us think that IV is better than PO, but what does this even mean? So part A of this myth is some people might think that IV is associated with higher treatment success. So this is false and has been repeatedly debunked by multiple RCTs. There's actually no study that shows IV is better than PO. In fact, some studies show that PO is better than IV, such as for pneumonia, gram-positive bacteremia, and even infective endocarditis. So I don't think there's a reason to believe that oral route is inherently better or more efficacious. It's just that in studies when they compare IV and PO, the IV and PO drugs are from different drug classes. So any difference in outcomes might be due to differences in pharmacological properties. And often the oral agents have antitoxin or anti-inflammatory properties, such as macrolides, tetracyclines, and fluoroquinolones, which could affect the outcomes. So currently we have RCTs to support the use of oral agents to support the use of oral agents either as initial therapy or as transitional therapy from IV therapy for all these conditions you see there. So this is a summary table of RCTs that compare IV versus PO for 3 major diseases that are often treated with IV only. So bone and joint infections, bacteremia, and infective endocarditis. As you can see, there's no RCT that shows IV is better than PO. And I assume that superiority studies are not done because our default position, which is based on expert opinion and decades of historical dogma, is that IV is better than PO. So people don't feel the need to do such studies. But in contrast, there are plenty of studies that show oral is just as good as IV, in some cases better than IV. So these studies have already been incorporated into recent guidelines for osteomyelitis and infective endocarditis, which highlights the role of oral therapy in these conditions. So these are the 2 guidelines that I use. Okay, continuing on with myth number 1. So part B of this myth is maybe IV works faster than PO. So it's hard to tell. I mean, the patient has been sick for several days, sometimes many weeks. They can probably wait 1 to 2 hours for the orally administered drug to be absorbed into systemic circulation, as long as they're not septic or super sick. So although you reach the peak concentration faster and you achieve a higher peak with IV, it doesn't necessarily translate to faster resolution of infection or improved outcomes outside of critical illness. Okay, what about is PO absorption reduced with systemic illness? So it's generally not unless the patient is septic. You still get adequate drug exposure even when the patient is febrile. Okay, what about IV administration leads to better tissue penetration? So this is not true. So tissue penetration does not depend on the route of drug delivery. It depends on the intrinsic property of the drug itself. So here's a simulation of free drug concentration at steady state for an antibiotic with a 100% oral bioavailability that's given every 8 hours. So diagram A is the plasma concentration. A 1 hour infusion intravenously gives you a higher peak level than a 3 hour infusion and an oral administration. But the treatment success doesn't really depend on plasma drug concentration unless it's an endovascular infection like infective endocarditis. So the tissue concentration at the site of infection matters more. So in diagram B, this shows you the tissue concentration. You can see that the drug concentration is virtually identical regardless of how the drug is administered. Okay, moving on to myth number 2. Systemically unwell patients should receive IV therapy. So IV is preferred in sepsis and septic shock due to concerns for reduced drug absorption from the GI tract because of gut hypoperfusion. Also, we generally use very broad spectrum antibiotics in sepsis and septic shock, which only come in IV formulation like meropenem, piptazo. And starting with IV and switching to PO after the patient improves is a common practice, but it implies that IV is better. And the optimal timing to switch from IV to PO is unknown in many infections, and mostly it's arbitrary. So there's evidence that shows using oral therapy up front in systemically unwell patients with things like cellulitis, pneumonia, even right-sided endocarditis in people who inject drugs, and pyelonephritis is just as good as initial IV therapy. So I've often wondered why the intensity of the immune response should direct the route of antibiotic administration. Moving on to myth number 3. So when oral antibiotics fail, switch to IV. So this is a very common practice. So when you say that patients failing oral antibiotic, you have to be very careful about this because it's factually incorrect unless you've tried every oral agent, right? So blaming the oral route for treatment failure is a gross misunderstanding of antimicrobial therapeutics. So if you do decide to switch from PO to IV, consider other reasons for doing so, such as you need broader spectrum of activity. You need a drug that penetrates certain tissues better. You want to avoid certain drug-drug interactions, etc. And when the treatment is not working, it is common to reflexively switch to IV, but do consider these factors before making any change. So it can take a few days to see a clinical response, so please be patient. Perhaps there is no infection and you're treating an infection mimicker. Maybe you're using the incorrect drug, or you're using a suboptimal dose, or the drug doesn't get to the site of infection. You might not be covering the right pathogen. There may be a complication such as an abscess that needs to be drained. So using IV therapy does not solve this problem. Okay, myth number 4, antibiotic language is not important. So the language we use around antibiotics can bias us in favor or against certain treatments. So sometimes people use the word, oh, this is a strong or weak antibiotic, usually equating that to broad spectrum or IV administration. But there's no such thing as a strong or weak antibiotic. There's only strong and weak prescription. So when you're using antibiotics correctly, every drug is effective. And when you're converting from IV to PO, people tend to use words, let's de-escalate, let's step down, let's downgrade. I don't like this language. It implies that you are reducing the intensity of treatment. And so I would prefer to use a more neutral term like transition. Okay, so let's talk about where this belief of IV superiority came from. So it likely stems from the era of when commercially available penicillin was introduced. So in the 1940s, penicillin was given by injection, had a dramatic effect on infection outcomes. And, for example, infective endocarditis used to be a death sentence until penicillin came along and drastically reduced the mortality. And then many years later, they released primitive oral antibiotics with low bioavailability like tetracyclines, erythromycin. These were seemingly less effective for serious infections such as endocarditis. And experts at that time concluded that intrusive IV treatment was better. And so this deeply entrenched dogma was well established before we had RCTs to properly investigate the efficacy of certain drugs. And this belief was unchallenged for decades until the 1990s when we finally started to see the first RCTs emerge. Okay, let's move on to case 2. So you've got a 78-year-old female with left foot ulcer that's complicated by osteomyelitis. A wound swab grows MRSA, group B streptococcus, Haemophilus parainfluenza, and mixed anaerobes. She appears well with moderate signs of inflammation to the left foot. Vital signs are normal, blood work is unremarkable. So what treatment regimen do you recommend? So you can do oral amoxiclav plus doxy for 6 weeks, IV vancomycin plus IV amoxiclav for 6 weeks, do IV treatment for a few weeks, then transition to PO to finish 6 weeks. Start with IV, then transition to PO depending on biochemical response, guided by things like CRP. So most of you chose answer A, oral therapy up front. Some of you picked IV for a few weeks and go to pills. So all of these answers are technically correct, all right? But only one of them is, the most patient-friendly and probably the least harmful, okay? So I will show you what happened to this patient. So she was started on oral doxycycline plus amoxiclav for 6 weeks. Her infection did resolve, but unfortunately, because of ongoing risk factors from neuropathy, she had recurrent infection to this same foot. One might argue, why not try IV if she keeps getting recurrent infections? So my response to that is IV does not get rid of her risk factor, so the route of drug administration is completely irrelevant. So it is unfortunate that IV antibiotics are often overused. And in this study, where they had 148 patients on outpatient IV therapy, 58% had an infectious disease consult. They determined that 41% of patients probably did not require IV therapy. This was made up of 30% who could have been switched to PO, plus another 11% who didn't even need antibiotic at all. And interestingly, 22% of these inappropriate IV prescriptions were recommended by an infectious disease doctor. Here's a recent study done by my colleagues at VGH. They looked at the prescription of IV antibiotics that have an oral equivalent with high bioavailability, such as ciprofloxacin, clindamycin, linezolid, and they found that 62% of patients could have been on oral formulation instead. And so they were looking at this from a planetary health lens. And so they argue that if you could use more PO therapy, you can reduce greenhouse gas emissions. This is an audit of IV prescriptions done in Fraser Health Authority, looking at antibiotics with an equivalent oral form, just like the previous study. And they found that 51% of patients could have started with oral therapy or switched from IV to PO, and that 70 days of IV therapy could have been saved. So the agents at the top in the dark green have both IV and oral formulations. They also have excellent oral bioavailability and should almost always be given orally unless there is a compelling reason to give it intravenously. Fluoroquinolones and Cetra have slightly lower bioavailability, 80 to 90%, but is also generally recommended to give these orally when feasible. The rest of the antibiotics do not have an interchangeable IV and oral formulation, so the oral dose is usually lower than its IV counterpart, but as long as enough of the drug gets to the site of infection, the bioavailability probably doesn't matter all that much. This is an audit I did at RCH OPAT in 2024 to evaluate the appropriateness of IV prescriptions. So these are patients who were referred from the ER to OPAT for IV antibiotic. 82% of patients had a confirmed bacterial infection, but only half of them met criteria for IV therapy. I will show you these criteria later on. The most common infections were skin soft tissue followed by urinary tract infections. And the reasons for prescribing IV were most commonly hemodynamic instability, waiting for culture results, or patient was not able to tolerate oral therapy. And overall, IV therapy was likely not needed in 59% of patients. So now I'm going to pick on cellulitis because there's a common outpatient infection that's often treated with IV antibiotics. So these are 3 guidelines with their recommendations IV therapy. Up to date says give IV if there's systemic signs of toxicity. IDSA, which is Infectious Disease Society of America, and Fraser Health Authority guidelines say give IV if you have a moderate non-purulent cellulitis. And moderate means that the patient has some systemic signs of infection like fever, tachycardia, etc. But you only give IV for severe purulent infections. And if it's moderate purulent, you give oral. So this doesn't make sense to me because for non-purulent cellulitis, which is usually caused by beta hemolytic streptococcus, such as group A strep, purulent cellulitis is often caused by Staph aureus. Both are aggressive pathogens. Why are we giving strep IV and Staph aureus PO? So I'll talk about 2 RCTs that kind of challenge these guidelines. So this RCT was done in BC. They randomized over 200 patients with mild to moderate cellulitis to either cefazolin plus probenecid or cephalexin. So they were allowed to have systemic signs of infection such as fever. The cure rate in both groups were very high, 100 versus 98%. This is the second RCT conducted in Australia. There were only 47 patients. They were referred for IV therapy from the ER because they were judged to have high severity infection or they quote unquote failed oral antibiotic. So they either had IV cefazolin or PO cephalexin. Clindamycin was used if they were allergic to cephalosporins. So as you can see here, the oral group actually had more systemic symptoms and signs of infection, such as fever, tachycardia, and elevated inflammatory markers. So you might think, well, this study will be biased against the oral group and the IV group probably will do better, right? Actually, that was not the case. The PO was just as good as IV. In fact, there was only one treatment failure in the oral group, while the IV group had 5 failures, but this was not statistically significant. And so these two studies tell us that for patients with cellulitis who are systemically unwell and they're not hospitalized, there is no justification to use IV upfront. PO can be used. Okay, so now I'm going to pick on pyelonephritis, which is also commonly treated with IV antibiotics. So across the board, these 3 guidelines suggest giving 1 dose of broad-spectrum, long-acting antibiotics such as ceftriaxone or ertapenem, followed by oral therapy for outpatients. So that means these patients would have to go to the hospital or an infusion site to get the first dose before they start on oral therapy. But does giving the first dose intravenously actually make a difference? So actually it does not. Okay, all it does, it increases length of stay and cost in the ER. So there was a small systematic review of 3 studies which did not find any differences in outcomes in patients getting a first dose intravenously or orally. And in children, an initial IV dose also did not make a difference. So as long as you think there's an effective oral drug, then you can give the first dose orally, as long as the patient's not vomiting, right? So go with IV first if patient's vomiting or sick enough to require hospitalization, or if you suspect a multi-drug resistant pathogen. Okay, next question for you guys. So which of the following statements is true? IV antibiotics are superior to oral antibiotics for treatment of central nervous system infections. Oral antibiotics can be effectively used in patients with septic shock. Use of oral antibiotics compared to IV antibiotics is associated with early hospital discharge, or patients generally prefer IV over PO for infections. So 80% of you guys picked C, use of oral antibiotics compared to IV is associated with early hospital discharge. This is very true. So I will talk about CNS infections in the next slide. Regarding option B, so it is not recommended to use oral antibiotics in septic shock due to concerns for the gut hypoperfusion and malabsorption of orally administered drugs. As well, you need antibiotic in systemic circulation as soon as possible in septic patients, so you don't want to be messing around with giving oral agents. And then for answer D, the literature shows that patients often prefer oral medications for not just infections, but also for autoimmune diseases and cancer. Okay, so I've not seen any RCTs of oral versus IV antibiotics for bacterial CNS infections. There is an RCT that's looking at partial oral therapy versus IV therapy only for bacterial brain abscesses. This is ongoing. Theoretically, oral agents that have good penetration through the blood-brain barrier should work. And just because you can give a drug at high doses intravenously, it doesn't necessarily mean it crosses the blood-brain barrier well, right? So these are some examples of infections where examples of infection of the CNS where we use oral therapy up front, and it is the standard of care. So TB meningitis, neurocysticercosis, coccidioidal meningitis, toxoplasmosis, and CNS Lyme disease. When you compare objectively the pros and cons of PO and IV, it becomes clear who the winner is. So if you take pills, that's much more convenient than being tethered to an IV pole every day. Mobility and day-to-day function is limited by having an IV line. Patients often express concern about the discomfort of the IV. They're not able to shower comfortably. It's affecting their daily activities. And the IV line itself is associated with complications such as thrombosis, infection, bleeding, etc. And being on IV means more medical contact. So this could be good, could be bad, depending on how you look at it. But that also means staff workload is increased because it takes more time to prepare and administer an IV drug than it is to give it orally. And many studies have shown that The faster you get patients on oral therapy, the faster they get out of hospital because you're not waiting for a PICC line to be put in. You're not waiting for outpatient IV treatment to be set up, which can take a few days. So nowadays, outpatient IV setup could be viewed as a barrier to discharge. And if you use the pills correctly, they are far more cost effective and generate a lower carbon footprint because there's more garbage that's produced from making and administering an IV drug. So although some pills might cause more GI side effects, this can be managed and is rarely a major problem. And lastly, good bioavailability is often emphasized when using oral antibiotics. I mean, the amount of drug that you can pump into a vein far exceeds what a patient can tolerate orally, but more drug isn't always better, right? As long as you get enough of the drug to the site of infection, that is all that matters. So these are the criteria that I use for starting with or transitioning from IV to oral therapy. So first is there's a safe and effective oral option that will kill the invading pathogen. It will penetrate the site of infection. It does not cause any significant drug-drug interactions. There's no drug intolerances. It does not aggravate a patient's pre-existing medical condition, and there's no concern for dosing in obesity. Number two is the patient has a functioning GI tract. Number three, patient is stable. So this means different things to different people and varies for different infections. So in general, if it's an outpatient, they're probably stable. You can also include things like normal vital signs. There's no unexpected worsening of inflammation or infection. They're off vasopressors. They had clearance of blood cultures if relevant. Number four, there is no source control problem that needs to be addressed, such as drainage of an abscess or removal of an infected implant. And the last one is there's no psychosocial reason to prefer IV. So for example, patient refuses oral therapy, they can't afford oral medication, etc. So I created these diagrams to highlight what I've witnessed in my own clinical practice. There is a lot of fixation on the route of drug delivery despite all these existing RCTs. So I find that people often overemphasize the IV route as being superior and other factors are less valued, which is the diagram on the left. So in fact, sometimes asking if the drug should be given orally or intravenously is a completely irrelevant question and distracts us from more important aspects of infection management. So in my opinion, I think the IV route is not as important as many people think it is, and it probably carries the same or less weight as the other factors I consider when choosing an antibiotic. I would say controlling the source of the infection is the main strategy whenever possible. And whenever I ask trainees, suppose you had a pleural empyema and you can only choose one treatment, would you go with antibiotics or a chest tube? They always pick the chest tube. So there are also several recent RCTs that have compared short versus long durations of treatment for different infections. I highlight these studies because the question of IV or PO is not even a consideration here. So in the diabetic foot infection study, patients were on IV for 2 days before being switched to PO. For septic arthritis, median IV duration was 1 to 2 days. In prosthetic joint infections, IV was given for 9 days after surgery. In an ongoing endocarditis trial called POET2, patients who meet criteria for oral therapy are expected to be switched to PO after a couple of weeks of IV. So as I mentioned earlier, the non-inferiority of partial oral therapy was already demonstrated for endocarditis in an earlier trial called POET1. So there's always counter arguments to using PO. I just highlight some of them here. So first is there's not enough evidence for PO, or evidence does not apply to my patient. So there is way more evidence to support PO than IV. Problem is that people default to IV as their main position. And we have studies that are constantly trying to prove oral is just as good as IV. But maybe we should be having studies that try to prove IV is better than PO, since so many people believe that. And adopt that PO therapy should be the default position until proven otherwise. And if RCT is not enough to inform a change in practice, then it should mean that the current practice standard is based on even better evidence. But in infectious diseases, the preference for IV comes from historical practice that is based on expert opinion. So I think we should respect the hierarchy of evidence and treat any RCT as superior to an expert opinion, no matter how long it has prevailed. Right? So there's no perfect evidence. And if you're waiting for the perfect study that perfectly matches your patient's condition, that might not ever happen. Okay, number two, adherence is better with IV. So I'm not actually sure this is true, as the route of drug delivery doesn't really make a patient more likely to take the drug. A patient on outpatient IV therapy still has to come in every day to clinic or hospital for IV treatment, or they have to administer the drug to themselves at home. So what we do know that reduces adherence is the number of pills and frequency of dosing. That's why we try to choose IV agents that are given once a day or pills that have less frequent dosing. And oral therapies, number three is oral therapies have too many side effects. So there might be a high risk of GI intolerances, but the oral route is not intrinsically associated with more side effects because that's related to the drug class itself. Mainly due to IV complications. Or IV has been standard of care for decades, and we know it works. Well, that might be true, but think about what evidence supports this standard of care. So shockingly, it's just expert opinion, but that should be easily overruled by an RCT. So just because it's been done a certain way by many people for a long time, it does not mean it will always be the best way to do it. So these types of counter arguments are reflective of the barriers to change at both individual and system levels. So clinicians might be out of date with evidence. They might not have experience using oral therapy. They don't feel comfortable. There might be a fear of litigation, or there's no incentive to change. And it's these collective individual barriers that create the system barriers. So people build models of care that heavily favor IV therapy. So IV treatment is all publicly funded while patients have to pay out of pocket for oral therapy. We dedicate resources to support patients on outpatient IV treatment, but not for patients on oral therapy. And many guidelines are outdated and prefer IV as well. So when you overcome these barriers, then you can restructure your model of care like what we did at our two sites. So I work at Royal Columbian Hospital and Eagle Ridge Hospital. So we started this program called COPA, which stands for Complex Outpatient Oral Antibiotic Therapy, that was integrated into the existing infrastructure of our home IV program. This is not a new concept. This model of care exists in the UK and the United States. So patients with complicated infections who historically were treated with home IV antibiotics can now be treated with oral therapy and receive the same level of monitoring, support, and care as home IV patients through this new program. So in this retrospective review of the first 103 patients enrolled in this program, we found that the most common infection type was bone and joint infection, followed by intraabdominal infection. We even had a few patients with infective endocarditis. Most common antibiotic use were amoxiclav and doxycycline. Note that patients can be on more than one drug. 84% of patients achieved clinical success, which meant resolution of infection at the end of treatment. 6% had a partial response, which meant they were switched to another oral agent due to side effects with the first one, or the course of treatment was extended to cure the infection. So overall, 90% had a good outcome. Only 10% failed, which means they were switched to IV for any reason. 20% had some side effect, mostly gastrointestinal. 12 of these patients were readmitted to the hospital, half of which were related to infection, half of which were not. Nobody died at the 30-day follow-up, and there was no loss to follow-up. So at Royal Columbian Hospital, which is my main site, the number of patients we refer for home IV antibiotic has been declining since 2020, which reflects our use of more oral therapy following the publication of several RCTs. So as you recall, 2020 was also the start of the COVID pandemic, which also helped us to realize the benefits of oral therapy. So patients on pills can be discharged sooner. They don't have to come in every day for IV treatment. As a result, there's reduced hospital congestion and medical contact. And so potentially we hope to reduce COVID transmission. So through this program, we estimate a cost savings of over $250,000, averaging $2,500 per patient over that 1 year period. This figure does not factor into account the cost savings of earlier discharge from hospital and avoidance of PICC line related complications. Okay, so in summary, hopefully I've convinced you that pills are just as effective as IV when used properly. Oral treatment offers so many more advantages compared to IV for patients, system, and the environment. And I think based on the totality of evidence and the disadvantages of IV, oral therapy should really be the default mode of administration for stable patients, unless there is a good reason to use IV. And one could argue that IV treatment is substandard care in some situations, given what we know. I think we should only be reserving IV therapy for those who are not yet stable, they're critically ill, they have a non-functioning GI tract, or for infections where there is not yet enough evidence to support oral therapy. So with that, I'm finished my talk. Thank you for your attention and happy to take any questions.
Great, thanks, Davie. That was amazing. I'm going to start, because I'm the moderator, I'm going to take the first question. So I presume that some of your colleagues would disagree with your position. If we were to ask the colleagues that disagree with your position that PO should be preferred in most cases, with the caveats you've outlined, what would they say? what are the main reasons that they would disagree with you?
I mean, it's basically those four counter arguments I highlighted there.
Okay.
That's why I mentioned them in this presentation.
So that's the sum of the counter arguments. Okay, thank you for outlining that. So a couple of questions that are related, so I'll combine them. Someone was asking about the studies, and do any of them include chemotherapy or immunocompromised patients, or what about the frail elderly? So in general, for those sort of niche groups of patients, would your conclusions apply?
So in many of these RCTs, the severely immune compromised are excluded. Same with pregnant patients. And so, yeah, so we're kind of cherry picking certain patients in these RCTs. So being immune compromised does not preclude you from oral therapy as long as they meet those 5 criteria that I mentioned. Major consideration of the immune compromised patient is that we fear that they get worse very quickly and they get nasty infections with multi-drug resistant pathogens. And I would say that that is the reason why we often choose IV for them, is because there is no oral drug that is broad enough to use. So if pip/tazo, meropenem came in oral form, it's hard to justify using IV for the entire treatment course for those types of patients. And for frail elderly, my answer is the same for them. You know, like even if they're, you know, if 90-year-olds were excluded, it does not mean that the evidence does not apply to them. You still have to extrapolate, but as long as they meet those 5 criteria, I don't see why they can't use PO, right? So like I said, as I alluded to, there's no perfect evidence, there's no perfect study. If you're waiting for that perfect study before you use PO, then I think we're not really going to advance the field here. And if this evidence is not enough to convince people to use more PO, then you should have some evidence to justify your current practice standard.
Fair enough. Next question. Someone pointed out that they recall seeing some research where people on IV antibiotics were also given ibuprofen, and that resulted in a quicker transition to oral and faster clinical improvement. Are you aware of that literature, and what are your thoughts on that? Has it been debunked or replicated?
The only condition that I'm aware of where we use ibuprofen in a study was skin soft tissue infections. If they use NSAIDs or steroids, it does reduce the inflammation faster. I'm not familiar with the particular study that is being referenced here. I assume that you mean like the patients on IV, they're given NSAIDs, their inflammation resolves faster so that it can be switched to PO. My point is that you don't have to wait for the inflammation to come down before you switch to PO. Right? That's what I'm trying to argue.
Sure.
And, you know, using ibuprofen is helpful for relief of symptoms. I would use it for that reason, but I would not use it as a justification to switch the patient from IV to PO sooner.
Great, thank you. Another question about the IV lead-in in some of these trials. So can you remind us again, based on the literature and your opinions, are there any situations where IV lead-in is required, and what are they and how long? In the indications that you talked about, just immediate starting on oral is fine.
Yeah, so there's no minimum duration of IV lead-in. Every RCT will do a different number of days. So in the largest study, like a bone and joint infection with VIVA, I think it was like a week or 8 days. For endocarditis and POET, it was like average 2 weeks. And then for other studies, it was oral upfront, IV for a few days, then do PO. My interpretation is that it's fairly arbitrary, but you know, so as long as you meet those 5 criteria, no matter how many days of IV it takes, you potentially could switch to PO fairly quickly. You need to do 2 weeks of IV for endocarditis before going to PO. You might not have to. I would follow the evidence, but the answer to minimum duration of IV lead-in, there is no real minimum duration.
Thank you. Someone's asking about the role, and if there's any role for intramuscular antibiotics for acute infections to avoid ED visits.
So the only infections that I'm aware of where we use intramuscular antibiotics is syphilis, you know, IM penicillin, and gonorrhea. So IM ceftriaxone. I myself don't regularly use IM antibiotics in my practice. I mean, I'm not sure if that's better for patients as opposed to IV. I mean, I would imagine it hurts every time you get a poke in your muscles. So we generally don't use it.
Okay. And just your thoughts or comments on patient preference, social issues, homelessness, and the organization or logistics required to pick up and pay for oral meds versus coming to the ER at night for IV antibiotics. Any personal experiences or thoughts on that?
Yeah, this is challenging population. So if you have mental health issues, you're unhoused, substance misuse. These folks are very difficult to engage and maintain in care. So I often do see them come to emerge. They get referred to me in OPAT, they never show up, or they show up intermittently, even though they're prescribed IV. And so I know in other places, there's a system developed to support these folks. Unfortunately, at my sites, we don't have it. We just give them a prescription. We're not sure they fill it, or they get prescribed IV treatment in OPAT. We're not sure they come in every day, or they come in sporadically. You know, in my opinion, for these folks, I think if they're properly supported, it might be easier for them to just have some pills in their pocket to take, as opposed to having to arrange transportation to come into hospital every day. So compliance might be improved if we're able to somehow support these folks using pills, as opposed to making them coming every day for IV treatment.
Okay. A question about the medical legal concerns. Given that IV is established despite the evidence, should prescribers be concerned about medical legal issues and the risk of being sued or anything like that? What's your opinion on that?
So I did highlight that point. I think it's more of an issue in the United States. And unfortunately, there's so many folks who deeply believe that IV is better. I would say is probably the majority, right? So the majority kind of establish this standard of care based on a false belief system, which is very unfortunate, because if you follow the evidence, the truth is the IV is not better, it's probably more harmful in many patients. So, you know, I think like the concern about being sued is legit, but it's also stopping us from advancing this field like we should, right?
Sure.
So if more people adopted this position, then we can establish a new standard of care. And maybe people would think differently, like, oh, if you're giving me IV and then I get a blood clot from my PICC line, I should sue you, right?
Sure. On a related note, we've had the same question about adhering to guidelines or not, and are there any medical legal concerns? And we had consulted the CMPA about this. So I'm no expert and don't ask them for the official stance, but what I recall them saying is, if you leave an intellectual footprint in the medical record that you're aware of the evidence, in this case, in support of PO, you have a discussion with the patient, and you document a shared informed choice, then that you may be sued, but it won't be successfully. So that conversation and reflection on the existence of evidence that shows PO is safe protects you from all of those concerns around medical legal risks. So, but I would double check with the CMPA. A question about the difference in antibiotic resistance with oral versus IV.
I think the route of administration matters, right?
Okay.
It depends on the barrier to resistance, right? Like quinolones, you can develop resistance very easily. Doesn't matter if it's IV or PO. It also depends on the bug. Some bugs develop resistance on IV treatment, like Pseudomonas. So the route of administration is completely irrelevant.
Okay. And then any suggestions for follow-up? So if you put a patient on oral, does your follow-up or monitoring plan change?
Not really, because with our COPAP program, all these patients are treated the same way like a home IV patient. So they're getting reassessments from the doctor every couple of weeks. They're getting blood work every 1 to 2 weeks. It's exactly the same follow-up. So this is what I'm trying to propose, is to even the playing field. So people on PO should receive the same level of care monitoring as patients on IV. The reason why IV patients get more monitoring right now is because they are more medicalized by having an IV line and needing a nurse to administer the IV drug. Right? It doesn't mean that their infection is less complicated or that they don't need as much blood work monitoring. They need just as much. So in a way, you can argue that IV is over-medicalizing patients when we don't have to.
Okay. So here's an interesting point and then counterpoint in the chat. So someone's saying bioavailability, site of infection, penetration of antibiotic at the site, inoculum effect, severity of infection must be considered in conjunction with other factors before deciding which route of administration is preferable. And a comment that came immediately after is, many of these points are not true, as he is pointing out in his presentation. So I guess one person is saying, well, you have to pick based on a variety of factors, and someone interpreted your talk as saying that's the belief, but it's not necessarily true.
Yeah, so there are many factors to consider when choosing an antibiotic. The route of administration is just one of them, right? So I did mention, like, you have to consider patient factors, drug factors, severity of infection, all that kind of stuff, drug penetration. So all of this matters, but what I'm trying to say is that the IV versus PO route doesn't need to dominate your consideration all the time, right? So when you're deciding on a therapy, the first question that comes to mind shouldn't be, oh, should I give you IV or PO? First question, well, what's the first line drug? What's effective? Will it get to the site infection? Okay. Does this drug come in pill form? Yes. Let's give PO. It does not. Okay, let's give IV. So the question of IV versus PO should not be the first question. These other factors that was mentioned, yeah, definitely consider those first.
Okay. Someone's asking, the slide said oral if vitals are normal. So what about fever and tachycardia?
Yeah, you can totally give PO if they have fever and tachycardia. We do that all the time for cellulitis. It's been shown in 2 RCTs. We do it for pneumonia. That was the first few slides where I debunked the myth that if you're systemically unwell, unless you're septic, right, you can still use PO, right? If you're like people who are febrile, tachy, many of those are outpatients. Are we going to admit all these folks for IV, or are we going to send them all to OPAP for IV? It's just going to overload the system, right?
Mm-hmm. There's many more questions than we'll be able to get to. So as you have alluded to, there is often lack of support for COPAT patients versus IV OPAT patients. There's no COPAT clinic that I'm aware of. What would you recommend to do to overcome this challenge? Community pharmacies, GP monitoring, primary care networks.
I mean, that's
as
what I'm trying to push
examples.
for in Fraser Health is
Mhm.
to have a health authority-wide COPAT, right? So
Okay.
basically, patients with complex infections, endocarditis, osteomyelitis, that kind of stuff. If you use pills, there should be some public system for these people to be followed. And because we already have a outpatient clinic for home IV patients, why can't we just use this existing infrastructure and resource to follow these PO patients? It's really not that hard, right? Because you end up getting patients out of hospital faster. It's saving resources, it's saving time, saving money.
Mhm.
There's just so much benefit to it.
Mhm.
And maybe in the future, we can publicly cover these oral agents because it's not fair to punish patients financially for pills and then cover a more expensive IV treatment that's not more effective. It generates more garbage and it's more harmful. It just, in
Doesn't make
2025,
sense.
this doesn't make sense anymore, this model of care.
Yeah, I never thought of it that way. That's an ethical problem. Do PO antibiotics work as well as IV to take down the bacterial capsule that may protect bacteria from being accessed by the antibiotic?
Honestly, I don't know the answer to that. I would say that's probably not even a relevant question. It's not the fact that it's IV or PO. It has to do with the properties of the drug itself, whether or not there's actual in vitro activity against the pathogen.
Sure.
So my point about this presentation is let's not keep asking if the oral is going to do this compared to the IV. It has nothing to do with the route of administration. Because let's say I give you Cipro IV as opposed to PO Cipro. Like it's the same drug, right? So the
Sure.
IV and the PO route is not really relevant.
Yeah. And if that bacterial capsule issue was important, then that would manifest in differences in infection cure and things like that, which isn't what is being shown in the multiple RCTs that you're talking about. So I get your point. Someone's asking you to comment on what is mentioned in Bugs and Drugs, and they point out that in BC, a lot of people use the Bugs and
First
Drugs
line app.
app as the source of information.
I use it too. I use First Line app and Bugs and Drugs. I recommend those resources as well, right? So I like them. I don't know how updated they are in regards to endocarditis or osteomyelitis. I know in Fraser Health we are now putting out a prosthetic joint infection guidelines suggesting the use of more oral therapy.
Okay. This is an interesting question. Someone's talking about the term sepsis and it's being overused, that just because someone has a systemic response doesn't necessarily mean they have sepsis. And so can you comment on that? And have you done any education at RCH regarding sepsis or over labeling of someone as septic as a barrier?
Yeah, we use this term very frequently. It's thrown around. The definition of sepsis has changed over time. So if you want to be technical about it, the definition of sepsis is you have some sort of infection that's triggering a dysregulated immune response. That's what it means. How do you diagnose it? That's tricky because many things can look like sepsis but are not. And so the newest definitions suggest that if you suspect there's an infection and you wonder if they have sepsis, use the Q-SOFA or the SOFA score. So this is a measure of organ dysfunction. You can also use things like Muse or News. So these are all scoring tools that give you an idea of whether or not the patient is going to deteriorate and whether they have any organ dysfunction. It doesn't necessarily mean that organ dysfunction is from an infection. So that's why sometimes sepsis is hard to diagnose and it exists on a spectrum, right? And so previously they had SIRS as part of the sepsis criteria, but they got rid of it because it was not specific, and people were getting labeled as septic when they were not, and so there was overuse of antibiotics. So I think if you wanted to, diagnose sepsis properly, look at the latest sepsis guidelines, look at the definition. I wouldn't say fever and tachycardia automatically means septic, right? That's just not it. You need to have organ dysfunction.
Okay. So a question, can you say more about the carbon impacts of IV versus PO?
Yeah, I mean, I don't know a whole lot about it. I know that my colleagues at VGH have studied this. And so you think about how an IV medication is made, right? You're going through a lot of single-use plastic, needles, tubing, bags, vials, so lots of garbage, right? And so
That's right.
if I remember correctly, there was a study done in UK where they compared 1 week of IV Cipro to 1 week of PO Cipro. The carbon footprint of IV Cipro was 60 to 70 times higher than that of PO. I've not been able to see other studies that have compared different oral and IV drugs, but theoretically it makes sense. And over time, it's quite impactful, right? It's not just antibiotics; it's any IV drug in general, right?
Thank you for that. A question about perioperative antibiotics. Anything different in your conclusions about IV to PO in the perioperative antibiotic area?
Yeah, I don't really deal with this part as part of my practice. I have seen some guidelines of using combined oral and IV treatment, perioperative prophylaxis prior to colorectal surgery. My guess is that we're using IV perioperatively for practical reasons, right? You get the drug in fast so you can make the first incision quicker. It gets to the site of infection, or the site of surgery, the site of incision there. And then post-operatively, people might have nausea from the anesthetics, so you're probably not giving PO. So I think the reason to give IV perioperatively is more for practical reasons. I'm not aware of any studies doing IV versus PO for this indication.
Okay. And one last quick question and quick answer. For virulent infections such as Eikenella, Cordens, and Pasteurella multocida, should patients start on IV so you reach a steady state faster?
I'm not sure if you're referring to skin soft tissue infections or bone and joint infections or bacteremia. So it really depends on the clinical syndrome. It doesn't really depend on the pathogen, right? So I'm saying that the pathogen itself should not dictate the route of drug delivery.
Again, I apologize for not getting through all the questions, but thank you so much, Dr. Wong, for the wonderful presentation and answering so many questions. We really appreciate you sharing your expertise and your opinions on this and summarizing the evidence so clearly for us.